Good afternoon. Can you hear me and see me?
Yes, very well.
Thank you very much. I couldn't have been happier and more privileged to be introduced by such panel and Dr. Patakos. Good evening, good morning there to everybody. Indeed, a great honor to be part of this assembly, even though from the distance. Without much ado, let me share my screen, and you'll be fortunate to know that in the last few minutes I managed to chop my presentation down to a fewer slides. Let me see. Can you see my screen?
Yes. Yes, everything
okay. Excellent. I'm going on full presentation mode. Well, it is indeed a pleasure for another additional reason to be here today, because for the first time, you will not see my credentials under my name being assigned to Singapore in the National University of Singapore. And you will be witnessing more and more the futuristic images from Singapore being replaced by ancient cultural images from Greece. But I think it was mentioned already what's next to happen. In that sense, we don't need to waste any more time on that. Disclosures? Well, minimal invasive procedures can be many. Nowadays, we're moving towards minimal invasive approaches. They encompass mitral valve, tricuspid valve, aortic valve, combined surgeries, bypass surgeries of all sorts, ASD closures, and some other congenital disease procedures, MACE procedures, and, as I mentioned, congenital conditions. Now, there is little to argue about the pantheon of mitral valve disease. I may be forgetting some of our colleagues here, but I can't fit more on one single slide. The most known of all being Alain Carpentier at the top, the founder of modern mitral valve repair, whose principles of functional re-establishment of the mitral valve coaptation, physiological re-establishment of the coaptation, we still follow today. And I would say that my talk today is more suited and adapted to address the cardiological audience in terms of putting it in a context. What do we do during and for mitral valve repair in the operation theater? You may have heard or known that we can do in artificial cord implantations, smaller resections, rectangular, triangular, sliding plasties, butterfly plasties, cord transfers, shortening, and so forth. And part of most of our repairs is also implantation of a ring that comes also in different sizes and variable rigidity. We may use prefabricated multi-loops as well. Here you see the example of an asymmetric P2 prolapse. What do we usually use? We use single cords. We may put one cord on the anterior papillary muscle, another one on posterior papillary muscle. We may use single cords. We may use multiple cords, triangular or quadrangular resections, plasties, and so forth. I think it's important for the cardiologists as well in our respected audience to know what are the techniques we're using. We're going to talk about techniques and technologies. Now we have the Barlow's or form-fruste excessive tissue, hypermotile tissue, which makes it a bit more difficult for us to repair a mitral valve endoscopically or minimally invasively. But there are certain techniques, again, that apply. For example, cleft closures, partial resections, neocord implantations, sliding plasties, and so forth. Now, the Barlow's presents a more difficult target because oftentimes it comes with big clefts and very excessive redundant tissue, as well as commissural or annular disjointment. Now, I don't want to get too much into hyperspace theory, but minimal invasive mitral valve surgery is not the same. It's not equal minimal invasive mitral valve surgery. We all start, or most of us start under direct vision with without any assistance by cameras. Then we move on to endoscopic assisted minimal invasive mitral valve surgery, then totally endoscopic using 2D or 3D technology. There is robotic minimal invasive mitral valve regurgitation that did not actually establish itself widely around the world, ubiquitously for financial as well as practical reasons. It would be too long discussion if I went into that. And then, of course, we have the least minimal invasive of all minimal invasives, Anecdotally, I mentioned that once we have founded the Minimal Invasive Society of India, and I was propagating minimal invasive in the podium, and Gino Gerosa, who introduced the transapical neocords for the mitral valve, raises his hand and says, well, if you are minimal invasive, then I'm micro-invasive. Only then for a cardiologist to raise his hand and say, if you guys are minimal invasive, I'm nano-invasive. So in that sense, there are different worlds and different layers of minimal invasive. Benefits, as we all know, decreased risk of infection, less blood loss, less pain, less arrhythmia, less lactate, and higher albumin, as we have shown in our own series. The main benefit, however, is the better patient experience, faster mobilization, and as we know, mobility means life. And even after discharge, patient does overall better, decrease recovery time altogether, and return to full functionality in the daily life. I would like to raise an important point here. Why is minimal invasive important? Because it helps us customize and personalize the procedure. Until recently, or a few years ago, there was only black or white. There was median stenotomy and there is catheter. But now, having all these armamentarium in our hands, we can personalize the procedure together with the cardiologist, and we can offer the patient what fits that particular patient. So it's quite liberating. Now, the proportion, and I'll share a few of my experience or my outcomes as well. I think we should be going over to showing outcomes in series. The amount of cases that I do, and I think other minimal invasive surgeons can do as well, is quite high nowadays. So more than 95% of my mitral valves are done minimal invasively. Combined procedures more than 80%, MVR and atrial ablation more than 90%, and bypass surgery is not that high because there are a lot of drop-offs. Patients come, they get scanned, and then suddenly we see a porcelain aorta or many other difficulties that impede the femoral cannulation or positioning of cameras and tools in the chest. So not every coronary patient can be done like this. I would suggest the young surgeon who is transiting into minimal invasive to avoid certain situations and don't run into trouble, like flat-chested patients with verticalized hearts can be difficult. Very picnic habitus, severe obesity, and high standing diaphragm, extremely low ejection fraction, severely impaired right ventricular function, very severe pulmonary hypertension. Actually, the latest ISMIC's recommendation is for 75 millimeters of mercury, but and experienced surgeons goes even higher than that. Having said that, we must see the patient as a context. Severely calcified aorta or severe adhesions of the lung, forming irradiation, and so forth. There are a lot of surgeons who still deny minimal invasive and endoscopic heart surgery, and as I go around different countries, I keep asking those surgeons, why? Are you too old, too scared, no time? Is it a competition? Is it too difficult? Mostly is number 5 though, inertia and comfort zone, because we're habitual animals, we tend to continue doing what we feel comfortable with. Now, for the cardiologist again, this is the setup in the operation theater for a minimal invasive procedure. This is the access. I'm not going to go too much into the technicalities because they couldn't interest you less. And this is the femoral cannulas we're using for femoral cannulation. The upper left corner shows you the queen of all clamps is the Chitwood clamp that we use to cross-clamp the aorta. These are the retractors we put into the left atrium to open the atrium and visualize the heart valve. Parenthesis, there is allegations by those surgeons who deny minimal invasive or have never tried minimal invasives that visibility is not good. And these things they tell the patients, well, this is wrong, and I'm sure that Antonius will agree with me, nothing gives you such physiological view and position as well as testing of the mitral valve as you go compared to the mini thoracotomy on the right side. Face on the mitral valve, and you can test it without stress. Different specific instruments, and then again, as you saw, as I've mentioned, a right lower corner here, you get directly into the mitral valve. This is the positioning of the patient. This is an animated setup of the procedure. Femoral cannulation. Now, when you start your experience, so you have more complex cases to do, you may choose to add a retractor for better viewing and more space, as you appreciate here. And this is how a patient ends up to be. I like putting in 2 chest tubes, one JP drain and one pleural drain. And then you move on in your experience and you start getting totally endoscopic, for example, like here, where the incision reduces inside, even though literally I don't believe it makes a life-changing difference for the patient if the incision is 5 centimeters instead of 3 centimeters. If you follow certain rules, for example, no metal retraction, protection of the intercostal space, and so forth. Now, we have tools that facilitate this kind of procedure nowadays, 3D navigation, core knots, and so forth. There are other devices, for example, the endo balloons that you can use to clamp the aorta from the groin, which allow you to make the incision even smaller. Here we see the typical outcome after a minimal invasive procedure on the mitral valve. 3 weeks later, about 3-4 centimeter incision. Young people, older people, ladies with small or big breasts on the left-hand side. I apologize, that's an aortic valve implant. And here you see some good cases for minimal invasive mitral valve, and here you see a bad case for minimal invasive mitral valve, which I would recommend against in the young surgeon who starts his experience, because the moment you take this Marfan patient on the heart-lung machine, you see how high is his spine on the lateral view. The heart flips over to the other side, and while the mitral valve is verticalized, so the surgeon may have problems visualizing. Possibilities. We push the envelope with growing experience. We operate concomitant pathologies, endocarditis cases, and so forth. Here, it was a quadruple case, MVR, ASD closure, atrial ablation, and TVR. Now, the ASD had a big and flexible margin, so I went in, repaired the mitral valve through the ASD, closed the atrial appendage, closed the ASD, and then proceeded to replace the tricuspid valve because it was rheumatic and required replacement. You can do atrial ablation with all the new devices. You can stitch bypasses for the right coronary artery. I don't recommend it to try it on the left coronary artery. And then, of course, there is another more, I wouldn't say new kid on the block, but in some cases it's possible. I just jump forward in the interest of time. The transareolar minimal invasive mitral valve surgery, as you will appreciate here, you go through the mamilla, through the nipple, a 50 to 60% incision around the nipple, and the rest of the operation is done with the endoscopic camera. I'll jump forward to see what it means for the patient after a few weeks, namely you can hardly see a scar. And that is cosmetically and functionally very important for the patient. Now, in the minimal invasive setup, we must make sure we don't run into trouble, and if we do so, how to get out of trouble. In other words, you must know where to stop. If you have an endocarditis case, such as our friend Mario Castillo-Sang here, which is not superimposed by endocarditis vegetations, the endocarditis is healed based on a Barlow disease, a preceding Barlow disease, then okay, go ahead, take care of the underlying disease, and you're good. Even though Barlow's, as I said, and remember these images, hold those images in your mind, because you see, Barlow's can deceive you. You put 10 Gore-Tex sutures, 5, whatever, 15, and you think you've repaired it, and then you do the post-op TE, and you'll be disappointed because Barlow's can deceive you. So there is a lot of guesswork going on in the way we do our repairs, and that could be eliminated with some new techniques I will show you later. I wasn't so lucky in my case. This is an 81-year-old patient, which I did endoscopically. And then you see the valve is partially calcified. It has florid vegetations, perforations, and the annulus is affected as well. In this case, I constructed a neo-annulus. I didn't repair the valve. Put in a pericardial patch, which gives you indeed a very strong neo-annulus on the posterior side, and you can affix a biological valve after that. Meaning to say, I don't like too extensive leaflet augmentations and extensions, building the whole valve anew, as some other surgeons may propagate. I would like to stop where I feel I should stop the repair and replace the valve. There is another similar situation. Here you see a 51-year-old gentleman who was defaulting treatment. He came macerated with 38 kilograms of weight. In this situation, decompensated heart failure in the middle of the night, and he wanted me to do a minimal invasive. Okay, fair enough. Very flat chested, difficult access. You see the full length of my instrument disappears in the chest. And look at this Barlow's valve, which is superimposed with florid vegetations, huge clefts, ruptured cords. Would you repair this valve? I wouldn't. So I chose to replace this valve, and I show you the specimen once explanted. Look at these huge islands of bacterial colonies here. To me, that's the limit. You shouldn't try and repair this valve. Replace it and get out of the operation theater with the best possible impunity. Troubleshooting in minimal invasive mitral valve is usually about bleeding, conversion, and I always recommend the younger ones, bail out, convert on time, don't get into the catastrophe, don't try to fix problems that are very difficult to fix. For example, a massive bleeding from the left atrial appendage, or a free wall perforation of the left ventricle. Redo MVR, large right atrium, SVC, IVC, or very pressurized, no-go femoral, circumflex artery occlusion. These can be problems we have to troubleshoot in the operation theater. Now, in the interest of time, I'm not gonna go through many of those problems, but there are different bleedings, types of bleedings in minimal invasive heart surgery, each one with its own solutions. Minimal invasive is a lot, therefore, about tips, tricks to facilitate safe surgery. Good planning and patient selection is the key to success. New technology facilitates new solutions, ladies and gentlemen, but also may raise the bar for training. Combined cases of all sorts are possible, and I don't favor extensive patching. Good to know when to do something, but even better to know when not to do something and to stop. Some outcomes, you see that against some allegations of people who don't like minimal invasive, these are my own outcomes in the last year or so, the last few years. The pink upper side is minimal invasive, the below open. The blue boxes are the anticipated Euro score where we should be. You see the outcomes are far below the blue boxes, but in the minimal invasive there is a trend for better outcomes. Of course, here there may be a selection bias for the patients. Less hospital stay, equivalent non-inferior readmission 30 days from discharge, or rehospitalization. Therefore, minimal invasive is equally safe and efficient in selected patients. The innovation that is coming in, 3D, Cornot and RAM devices, automated devices that made our job easier. About 10 years ago, I introduced a uniport cardiac surgery that doesn't involve any femoral cannulation with a self-invented atrial retractor, so patient has hardly a scar in this context. Combined surgeries, and I'll spend just 2 minutes showing you the latest, which is my proposed minimal mitral valve repair techniques published in the European Journal and inspired from Greek technology and architecture, back-to-back papers in the European Journal. Techniques that I believe are more standardized, more reproducible, and can turn a junior surgeon into a solid mitral valve surgeon as well. For example, the Roman arch technique here, it works like this. I'm not going to show the video in the interest of time, just the animation. No guessing how many cords to put, where to put them. You just go into the anterior papillary muscle, travel along the prolapse, and go down the posterior papillary muscle. The same with the second part of the cord, and you land on the posterior papillary muscle, tie there, and you are done. You insert your ring, you test. It's a very dynamic repair method, and it distributes the tension across a long area, less risk for ruptures and calcification of the cords. I'll show you the Minotaurus, which really unties and cuffs your hands. It's a big help, I believe, in Barlow's or Barloid diseases. For example, this, you go into the commissure, anterior commissure, down the papillary muscle, across all prolapsing leaflets. You pre-close the clefts with that as well, and you exit in the posterior commissure. You may do one for the anterior, one for the posterior, or only one. You can close the cleft or add this individual cord as well. So please try it out, the surgeons among the audience, and tell me what you think. New tools, we invented a new retractor that doesn't require an external camera, gives you a very good view, as you will appreciate here. Here is a Roman arch technique I used recently in one of my patients. I won't stick to that. I explained the concept. I'll just show you the result. You can adjust, and when you are happy and ready, you do the final testing. And the result is really a very good one, and it took me only 5 minutes to apply the Roman arch technique for this patient. The same for the Minotaurus with the prolapsing tissue everywhere. Minotaurus technique, it looks like the horn of the Minotaurus. And the final result, it's not so much of an interest for the general cardiological audience how it's done, a small whiff, so very good outcome with one single running stitch. So training is very important. Obviously, we used to train like this with big books, now with YouTube. All these tools are available for minimal invasive heart surgery. New devices, simulators. We have an excellent simulation center here in Singapore. And I won't miss the opportunity to introduce my book, the first book dedicated with QR codes, where you can scan and see how the procedure is done. I would also like to praise the book by Joseph Zacharias, our common friend, on endoscopic cardiac surgery. With that, I came to the end of my presentation, and I'm closing the historical loop with Claude Lorent's Embarkation of Ulysses at the land of the Phaeacians, not yet arrived in Ithaca. Thank you very, very much for your attention.
Thank you very much, Theodore.